It's 8 o'clock and good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is about nutrition in children with inflammatory bowel disease. We are very, very happy to have Dr. Dhanasekhar Kesavelu, who will be delivering the talk. Moderating the session will be Dr. Pavana Kayastha. She's an associate professor, Department of Pediatrics and Vice Principal, Clinical Sciences at the Kathmandu Medical College, Nepal. Pavana did her MBBS and MD Pediatrics from Kathmandu University and received the gold medal for her MD Pediatrics. She has undergone SPEN training in pediatric nutrition. Dr. Pavana has 9 publications to her credit and is the principal investigator of an ongoing study. She has presented many papers and delivered talks on pediatric nutrition at national and international conferences and runs a daily specialty pediatric nutrition clinic in Nepal. She's an executive member of the Nepal Pediatric Society and the co-chair of the Pediatric Nutrition Chapter. Thank you, Dr. Pavana, for immediately accepting our invitation to be one of the moderators for today's session.
Thank you, ma'am.
Co-moderating the session will be Ms. Lekha Sridharan. She is the head of the Department of Clinical Dietetics at Apollo Children's Hospital and Apollo Women's Hospital, Chennai. Lekha did her BSc Nutrition and Dietetics from PSG College, Coimbatore, and MSc in Food and Nutrition from Mysore University. She's currently waiting to defend her PhD thesis. She's a certified pediatric dietitian, diabetic educator, and an SPEN LLL teacher. Lekha has several publications in national and international journals and has co-authored books on nutrition and is the co-editor of Child Nutrition in Health and Disease. She has presented papers and posters and has been invited faculty in national and international conferences. She is currently the National Vice President of Indian Association of Parental and Enteral Nutrition and also the Chief Program Officer of the Pediatric Core Group. Thank you, Lekha Sridharan, for joining our session. And I'd like you to introduce Dr. Dhanasekhar, with whom I understand you closely work.
Yeah, thank you, Dr. Vidya. Rightly said, Dr. Dhanasekhar is actually my mentor. He is the one who had trained me much further in the topic what we are going to discuss today. And it's really my honor to introduce Professor Dr. Dhanasekhar Kesavelu, a distinguished consultant pediatric gastroenterologist and also a professor at Apollo Health Research Foundation. Sir has over 70 publications, 4 textbook chapters, and he is an internationally recognized expert in his field. Sir serves as the honorary lecturer in the University of Liverpool. He has also led multiple multi-center studies as principal investigator. And Sir also has been awarded the prestigious Espagan Fellowship Award and the Espagan Young Investigator Award. And as a renowned speaker, Sir has shared his expertise globally. With a strong presence even in social media, Dr. Kesavelu connects with vast audience across YouTube, Facebook, Instagram, and I believe it should be over 1.5 millions. Maybe probably it's each day the followers keep increasing. So over to you, sir. We are all waiting to hear from you. Sir, you're on mute.
Just correcting it. Just give me a second, please. Yeah. Yeah.
Yes,
My screen, I'm just trying to get it. Just give me a second. And okay. Is my screen visible, guys?
Not yet, sir.
Not yet, sir.
I'm just wondering why my screen is not coming up because it's not allowing me to do a screen share. Yeah, just one sec. Now it's coming on. Right. Okay. Should be visible now.
Yes, sir.
Yes.
Lekha, thanks very much. I don't think I can be more humble than actually hearing an introduction from you. I know we are good friends for a long time. I'll tell you the story why I'm actually here. First and foremost thing, because it's very important. Because Pata sir actually got hold of me in Varanasi last couple of weekends ago and I said, Dhanasekhar, I'm going to kidnap you if you're not going to give me this talk. And then he said, Dr. Pavana is coming from Nepal, so it better be a good topic. So I just didn't have a clue till the last minute. I said, what shall we do? I thought, okay, right. We have done a lot of work in nutritional in IBD. So basically the thing, what we've been trying to do is one of the interesting parts of my journey from the UK to India has been to get something to be done for IBD because IBD is basically a tip of the iceberg what we see. So exactly, trust me, 14 years ago when I met Lekha first, I told her, listen, we have a lot of work to be done here. And that's exactly why I'm here this evening. Now, with all the thanks to Pata sir and to Lekha ma'am, I'm going to start this talk And I'm beautifully said by Hippocrates, because it's not an Hippocratic thing anymore, because we know that let food be thy medicine and medicine be thy food. What beautifully said, and this was not said just now, about 400 BC when Hippocrates said this. And so it turns out to be that nutritional therapy in inflammatory bowel disease remains a very pivotal element in the management of IBD nowadays. Now, when you look at this aims of the talk this evening, I'm not going to try and bore you to the core, because I have some very clear objectives lined up. The first thing is key elements of nutrition in pediatric IBD. Number two, overview on the various nutritional aspects. Number three is insight into exclusive enteral nutrition and Indian data. What really works and what does not work is what I would like to enlighten my friends this evening, which you could be a clinician, a dietitian, or nutritionist, anybody. The types of diet and its significance, because we talk about so many diets these days. We talk about the Atkins diet, the keto diet, basically blah, blah, blah. The list is endless. And the most important thing which I am as a pediatric gastroenterologist really is interested is basically gut microbiota and the diet component. So where does this all start from? Now, looking back at the recommendations, if you look at the ECHO Aspergan statement number 6, there was a 92% agreement in this particular statement where it says, in children with luminal CD, that is active luminal Crohn's disease, dietary therapy with extensive nutrition, exclusive enteral nutrition is recommended as the first line for induction of remission. And that's exactly what is the most important clinching point. Number 2, statement number 14, in children with low risk Crohn's disease who achieve clinical remission, monotherapy with maintenance enteral nutrition, at least 50% of daily energy requirements, can prolong remission. So here you can see two statements, one in support of exclusive enteral nutrition, another a statement which is slightly ambiguous, which tells you that partial enteral nutrition also works. That is an agreement of 87%. But the questions what this leads to is different things. We need to know the mechanism of action. We need to know the types of feeds. We need to know what is the evidence. We need to know the quality and the practical element of actually exclusive enteral nutrition or partial enteral nutrition. So when we look at this, the first thing which always goes back in my mind is to go back and look at the history. When did this all start? Interestingly, this started before I was born. So I think I'm a baby to this baby, because basically the nutrition part started in 1973. So some of you might have guessed how old I am, but that's a different story now altogether. But 1973 is when this first paper came. And in that paper, we don't have a name for Crohn's disease yet. You can see that they have given a name of regional enteritis, number 2, ulcerative colitis, and number 3, radiation enteritis. Here, you can see that they have a very complex group of patients. They are heterogeneous. They are adult patients. Some of them were cachectic. They had a complex disease phenotype, and some of them were awaiting surgery. The primary outcomes in this study was basically the betterment of nutritional status. There was positive nitrogen balance, which the researchers were trying to achieve, and fistula closure in Crohn's disease, because we all know that Crohn's can cause nasty fistulas. Now, the mechanisms is what we need to understand when you talk about exclusive enteral nutrition, because if there was one slide I need to pick up from a whole talk, I think it'll be this slide. Now look at this. You see EEN, and to achieve remission, you need to understand there are multiple confounding factors. Number 1, your microbiome has to be good. Number 2, you need to have an inflammatory milieu, because only when it's inflamed, it will work. When the gut is not inflamed, EEN will not work or PEN will not work. Metabolic products is very important. What metabolic products are we talking about? Short chain fatty acids. We talk about butyrates. We talk about organic acids. We talk about inorganic acids. And basically, that is very important. Cell-to-cell interaction is very important, which I will talk to you later on. And antigenic exclusion is very important, such as meat, milk, and all the possible allergic triggers. Now, when you look at the gut here, you can see that there are 3 different variants here. On your left side, you'll see the healthy gut. In the middle, you will see the Crohn's disease gut. And the last one is post-nutritional therapy. Now, this picture is interesting because you can see that the most important thing in the inflamed gut, where you see the Crohn's disease segment, right in the middle, you can see that there are certain foods that will actually aggravate the problem. So what foods aggravate the problem? You can see that processed foods, of course, on your left side, right in the middle, show that is going to aggravate the disease. And number two is basically your unprocessed foods, which is going to give you the anti-inflammatory effect. But more importantly, what you see here is the gut microbiota dysbiosis, which makes the problem complex. And you can see there are three categories mainly which I want to focus on. Number one, you have immune cells infiltrating into the GI junction. Number two, you have the pro-inflammatory cytokines. Number three, you have the infiltrated microbiota. These three are the most important things that you can see that are going to trigger the active disease process. Okay, now that is why I want to highlight this slide in the middle. And you can see that all these studies comprehensively are shown that the gut microbiota has been affected by exclusive enteral nutrition. Now, you can see that there are three studies which have shown that there is decreased diversity, particularly the nasty ones, such as the bacteroids like Prevotella and C. coccoides, have shown a drop in their levels once you put them on enteral nutrition. And this study, we are now going back to nearly 17 years from 2005, 2008, and 2010. And also in 2014, we saw that there is a decrease in Faecalibacterium proximity. Now, this is why the gut microbiota plays a part, because for us as clinicians, when you see a patient, you understand that they're growing well, they're putting on weight, and clinically they're getting better. But what you see at the microscopic level is this. Now, looking at this, I've also shown you how they've demonstrated is because they have done ileal biopsies in some patients where you can see that there's a reduction in the bacteroids and decreased proteobacteria. And also other tests, as you can see here, are basically the stool. All these have shown there is an increased bad bacterial count. So the metabolome, to make it interesting and important for the naive ones here, basically is to try and make you all understand that carbohydrate metabolism has switched to protein metabolism for the inflammation to settle down. There is an increase in sulfide, decrease in butyrate, which helps the gut maturation. Increase in spermidine, putrescine transport, which aids cell growth and healing. The three things that you need to understand I've highlighted, but there are other things that happen at a cellular level, including Th17 activation, TGF-B, IL-17, and the epidermal growth factor. So, what was the first study that showed that exclusive enteral nutrition is superior to corticosteroids? This is a meta-analysis. The meta-analysis basically showed a very important point where only randomized controlled trials were included. And of those 4 RCTs, 14 were observational studies. In this period particularly, we had, like in our Indian experience, a confusion what milk to use. So initial consideration was given to elemental formula, then hydrolyzed formula and polymeric. But in all these RCTs, you can see that there are different formulas that have been used. So what does this lead to? Interesting. We saw a reduction and induction in 6 to 8 weeks, but the studies here from the RCTs show induction starting at 4 weeks, 6 weeks in 3 patients, and 8 weeks in 7 patients. And you can see that the average clinical response for any child or in any patient for relapse, from relapse to remission, it's about 2 to 3 weeks time. So that's a very short duration, but with significant results. What is more important is this, that as a pediatric gastroenterologist, what I see from inside really matters. There are 3 boxes that I've highlighted. Number 1 is your endoscopic healing, because when we put patients on therapies, whatever it may be, steroids or nutrition or biologicals, we see 3 things. 1 is endoscopic healing. Number 2 is histological healing. And number 3, the important thing which we took into account is the PCDAI, or the Pediatric Crohn's Disease Activity Index, which tells you how the patient has got better. All these studies have shown a p-value of less than 0.001, which makes it significant statistically. And this data stands good from 2019 because there have not been much papers published on a similar topic from 2019 because of COVID and whatnot. What else do we see from here is very important because I have tried to put in a slide here. There are different types of formula. So people might ask, right, I'm from Sri Lanka, I'm from Nepal, I'm from this part, I don't get this milk, what do I do? No problem here, because the most important thing you need to understand here, in this slide, I pointed an arrow. Here you have a comparison between polymeric diet, semi-elemental diet, elemental diet, and steroids. One clearly knows that in these type of studies, the important thing is steroids are the ones which work very fast, very quick by reducing the inflammatory markers and promoting mucosal healing. But we all know that there are a lot of side effects. But then when you look at any other formula per se, you look at polymeric formula, you look at semi-elemental formula, you look at elemental formula, they are all the same. You don't see much of a difference here because you can see that on the chart in the box inside that there is relapse remission rates are different. But there is one thing common in all these studies is that they're all retrospective data analysis and all these patients were on 5-ASA therapy, which is mesalazine. So that is why we actually propose that any milk, any formula milk, whether you use polymeric, semi-elemental or elemental, they all work the same. And hence, to show you even more detail, the most important thing as a conclusion, what I could find from the studies is whether you use elemental or non-elemental, they both work the same. In case if you're not sure what is elemental and non-elemental, the answer is very simple. I always tell our patients a very simple thing. When the milk protein is intact, that's cow's milk. When the milk protein size is broken down, then that becomes a non-elemental formula. And when it's further broken down into a very small element, then that is called as elemental formula. So milk protein has a size and it's measured in a unit called Dalton, D-A-L-T-O-N, and that's exactly how the level is measured. Now looking at this, different types of formula, here you can see that there is enhancement with glutamine. You see that N9 fatty acid enrichment. There is comparative studies between low LCT and high LCT, low fat milk and high fat milk, and basically everything, the results were same. So this is a study from India. We published this data in basically 2021, so not long ago. And we found, me and Lekha, that there was not much difference, whatever formula that you use, whether you use semi-elemental formula or a polymeric formula, our data was quite good. And this was comparable with global data because we could find that our PCDI scores, for those of you who are unfamiliar, what is PCDAI? That is basically called as Pediatric Crohn's Disease Activity Index. That tells you how the patient was pre and post therapy. And that is basically what we tried and found out. And we found that whether you use semi-elemental formula or polymeric formula, the results are still the same. Now, more interestingly, this was also seen in studies which were published from global data. Now you see here, there are three categories I've given. So if you're wondering, does exclusive enteral nutrition work better? Does partial enteral nutrition work better? Does it work better with infliximab? And the answer here you can see that it actually, in exclusive enteral nutrition, 84% there was remission. Partial enteral nutrition, there was 64%. And with infliximab in the first group, whether you choose exclusive enteral nutrition or partial enteral nutrition, the results were much positive. 88% patients went into remission. And if you're going to think about basically the calprotectin level, which is a very sensitive marker to understand whether the patient is getting better or not, you can see that the fecal calprotectin level in combination, whether with nutrition or without nutrition, had come down tremendously in the first 4 to 6 weeks' time. So this is to give you an example. If you have a patient with IBD, whether they have Crohn's disease or ulcerative colitis, nutrition plays an extremely important role. And that is why you need to make sure the child or the adult you're treating is supported well. And hence the disease healing is much faster. Disease location also matters because I know here of the audience, the only person I could probably tell is Pata sir. because here nobody would operate on a patient with IBD. The most important thing is to always, the first lesson when I was junior, I was taught is do not invite the surgeon to the party. The reason is because the moment the surgeon keeps his hands on the gut, you're completely messed up. So I will not invite Patasa to my IBD party because he might come and cut something off and that might make it worse. So I would keep him last when everything fails. And the last thing I would do is to basically see where the disease is. So if my patient has got a disease exclusively located to the terminal ileum, I will be a bit excited because that is the part which really responds well to nutrition. We have seen, me and Lekha have seen in several patients, when we give them exclusive enteral nutrition, they do beautifully well. And that is basically one of the important things. If the disease is in the colon, nutrition actually works good. There are two areas where nutrition will not work. One is your oral disease. If a patient has got OFG, which is called as orofacial granulomatosis, then that patient can actually have exclusive disease located only to the mouth. If the patient has got perianal disease, that will be very difficult to manage as well. In those situations, your nutritional therapy will not work. Again, we looked at nutrition therapy, whether we do it for 6 weeks and 8 weeks. Our hospital data clearly says that if you give them exclusive enteral nutrition for 6 weeks, the duration or the remission was basically in 38.7. If you give them for 8 weeks, the remission rate is 31.3% with a mean increased weight of 4.31. And that just tells you how quickly one can get better with just nutrition therapy. And that's exactly why I'm here this evening, trying to actually explore a new concept and convince people that this is a very good thing. One more thing to also tell you whether nutrition therapy is working or not is to look at the predictors for response. Here we have the pediatric Crohn's disease activity index, and in responders, you can see that the response rate was very good. So there are two parameters. One parameter is the PCDAI and the fecal calprotectin, which can both be used as a screening tool, and it can also be used as a tool to actually see whether your patient has gone into remission or is heading towards relapse. This is an extremely important thing to look for. Now, post-exclusive enteral nutrition, what happens to all these patients? Interestingly, most of them actually remain in remission. Clinical remission is seen in 62% patients. We achieved remission in 80% patients, and remission was actually sustained for up to 62% patients. Interestingly, there were only 20% patients who were on nasogastric tube feeds. And while I was in the UK, what was interesting more is if the child is determined to have nasogastric tube feeds, they can put the tube themselves and give them the milk themselves. We have not seen that in India, but our remission rate has been extremely good. Relapse rates is very important because for maintenance of actual remission, you need to understand the child needs to be on immunosuppression. And the two common drugs that we use, one is thiopurine, another one is mesalamine. When we use them, these patients do very well from a relapse point of view. Compliance is interesting because what we see in Indian children is compliance is extremely good. And we have seen exclusive enteral nutrition from the age of 4 years, where the youngest patient has actually done very well for maintaining remission and basically has been only on the milk and nothing else. Now, when you compare EEN with infliximab, does it work better? Of course, it does work better. You can see that here because you can see when you combine nutrition and infliximab, better than the mono group, the combination therapy works beautifully well. Right. Long-term outcomes, we need to understand in N number of 109 from a study by Cameron et al., we found that remission was in 60%, relapse 58%, and the patient's time to relapse by after exclusive enteral nutrition was 6.5 months. The second therapy was 70%, and if you see that remission rate was 1/3, about 60% patients got better. Also, when you look at this, we need to understand the patient with IBD needs to be on a very decent diet for maintenance. Number one, we need to identify what are the foods that actually alleviate the symptom. So if a patient tells you there's one particular type of food that makes the symptoms worse, we tell them to avoid it we don't tell them to carry on because one food does not suit all. IgG exclusion diet has actually worked. Low flex diet has actually worked. Rapid food reintroduction diet has worked. So there are many ways of skinning a cat. We don't have one way. There are many ways of skinning a cat, and these are different ways of actually putting the patient back on a normal diet. Now, let's look at this a little bit more in detail. The first and foremost thing is dietary therapy for maintenance. So your patient's got IBD, you've given them enteral nutrition, they go into remission. What sort of diet should I give them? Now, when you look at that, the most important thing people forget is basically try and understand the amount of nutritional requirements that the patient actually needs. Here you can see that 59% of calorie requirement, if you give them, the relapse rates are delayed. So good calorie intake, they have a later relapse. Poor calorie intake, the relapse is much faster. So maintenance of enteral nutrition is a very important role, and you can see that in most of the countries, you can see that maintenance of remission is an extremely important category, and how people actually look to see whether the disease is better or not is only by looking at the fecal calprotectin. Real world survey has shown very important things in patient feedback. Now, when you look at the data, the most important thing is what we see all over the world is that there is very good compliance from the patient side, from the family side, from the medical team, from the formula type, and also in the economic cost. Now, you can see that the graph is coming down very slowly, which tells you one of the key factors in the management of inflammatory bowel disease is basically the economic cost. I'm not telling you that it's going to be cheap. It is expensive, but it's got no side effects, practically zero side effects, which makes it extremely important as well. So practices in EN, you can see that the therapy practice is different. In India, me and Lekha, we do it for 6 to 8 weeks, depending on how good the patient is. Then people ask us, do you give them anything else to eat? Yes. Now we, in our practice, allow them to have a handful of candy and 1 can of cool drink to keep them motivated for the day. But the rest of the time, they only take exclusive enteral nutrition. And that's very important because it is going to be a compliance factor, and the patient has to be positively motivated to help them actually continue the therapy for the entire duration of time. And we give them 120% of a calorie requirement, which makes them much more easier and compliant. Look at the support system. We not necessarily have all this, but global studies have shown there are multiple supporting systems. We see the dietitian as the lead support in the nutritional therapy for IBD, the nurse being the second one, the social worker, the psychologist, and the child health specialist, of course, somebody who helps with the coping so that they can actually motivate them. The gastroenterologist is not the best person to motivate because we are just too busy and crowded with work. So it's very difficult for us to tell them to just drink milk and not eat anything for 8 weeks. And the child will absolutely go mental when you tell them this. But some or the other, the dietitian convinces them. So I'm very thankful to our dietary team. Perceptions in EN, majority of EN studies, when you look all over the world, basically the perception is very positive. And the reason why positivity matters is when you look at the bar chart on the right side, you can see that children for basically any sort of diet, they are happy because now the world is going or being pushed towards a phase where people don't want to have side effects because of therapy. And that's exactly why this really matters. Now, what are the barriers? We have multiple barriers. The basic problem is the palatability. The problem is monotony because you have to drink the milk all day. It's the cost of the therapy, lack of support. It's too costly to the practice, too costly to the patients. There are multiple reasons. But hey ho, it works well because, as I said, once the patient starts doing it for 2 or 3 days, from day 4, day 5, they are the masters of the therapy and they will tell you how to do it better. Crohn's disease exclusion diet is CDED. It's a very tricky part because you can see this chart, and when you look at this chart at this time, when it's coming to your dinner time, most of you would be hungry by seeing this, because the things that you should not be eating on a CDED diet is basically soda, cake, sugar, cereal, and fruit juices. And we need to avoid emulsifiers, artificial sweeteners, sulfites, carrageenan, and taurine, which are very, very important, that needs to be avoided in the diet. Now, that is basically what it comes to. You have to give them a fiber-rich, a starch-free, low-fat, animal protein, non-containing diet, which is very, very difficult to eat on a daily basis. That's a no. And when you do this, the phases of the CDED are basically here. Phase 1, phase 2, and phase 3. We start them. You can see that this diet is going to be, quite untasty food rather. But then if you actually start using it, you get used to it by the first weeks and second week and third week. And there's some permanent restrictions which are very important, which are the soft drinks, processed meat, emulsifier, and gums. Crohn's disease exclusion diet has clearly shown that there is a sustained remission in multiple RCTs, and this RCT is an example which was published in Gastroenterology in 2019 with very significant p-values in the first tolerance, compliance, response, remission, and remission. Now, what else do we have to look here are just a few more things. Here, the last but few slides, I want to show you what happens to the gut microbiota when you put the patient on a particular diet. Now, when you put them on diets, what you clearly see here is very important. You can see that the patient's bacterial gut microbiota profile completely changes from bad bacteria to good bacteria. For easy understanding, you can see that the color charts here are basically an increase, and the red charts here are showing there is a reduction or a sustained. What we have seen studies all over the world where people have used the stool samples to look at gut microbiota analysis before and after using EEN has been a tremendous response in the improvement in gut microbiota. So Crohn's disease treatment with eating is a very interesting concept. This is called a CD treat. Now here we can see that the things to avoid or things to include are here: exclusion of gluten, lactose, maltodextrin, low fiber, minerals, and vitamins. And you can see that there is a huge chart that I put here, which exactly induces changes like what you will see in exclusive enteral nutrition. But then what we see in this data is the basic physiology and the mechanism how your gut is affected will be like nutrition, but the only difference here is you get to eat, whereas in exclusive enteral nutrition you get to only drink and not eat, and that's basically the compromise, and that's where my nutritionist actually comes in to help my patient. So CD treat in children, what has happened is there have been multiple trials, but unfortunately what has really happened is the studies 4 weeks was the maximum time that you can hold a child. After that, they become poorly compliant, they get really annoyed, and they drop out. So we never tried CD treat children in children in Apollo Children's Hospital, and basically that because we believe it does not work. Mediterranean diet, we all know, is very good. We see that the Mediterranean diet has got a rich diversity, and basically it's a very good portion that you cannot exclude, where you'll have to take a lot of good fats and less processed meats and red meat. This has also shown an extremely good result in Crohn's disease. That you can see, just to give you an idea, a lot of parameters that come down with PCDI and PUCI. PUCI is Pediatric Ulcerative Colitis Activity Index, CRP, SR, albumin. Multiple parameters have shown a drop in the level. Specific carbohydrate diet, again, is too complicated, but if you look at the chart, it looks good because basically here we tell you to avoid all the sweeteners, the sucrose, fructose, and all the processed foods. And this is going to be a lifelong therapy. This is not going to be short term, but the response is assessed between 6 to 8 weeks of therapy. So my conclusions and key takeaways for this evening in the 40 minutes that I was given to talk about exclusive enteral nutrition in children with inflammatory bowel disease. First is exclusive enteral nutrition is for induction in mild to moderate Crohn's disease. It is the equivalent of using steroids because it can give you exactly the same effect without the side effects of the drugs. Better mucosal healing, which is very important. 1 year relapse rates have been similar to patients who've been on therapy. Multiple, you need to understand MEN is multiple enteral nutrition, different types of nutrition. Any types of nutrition reduces relapse rate. But the major problem is your compliance, palatability, and cost. There are two types of diet I've just spoken about. One is your CD/ED and your CD treat, which are comparable. And finally, you can see that there are other types of diets which are used as adjuvants, which are extremely important as well. So I would like to thank Dr. Patta for the opportunity and giving me a chance to go through an extensive analysis of multiple types of diets that are used in inflammatory bowel disease, because these are not going to be easy and they are going to be very difficult in practice to implement. But what I can tell you and what I can vouch for is that we have used it and we have seen some tremendous effect with very good clinical success. And I think that has to be felt and seen rather than just being spoken about in a PowerPoint presentation. Thank you very much for your time, and I'm happy to take any questions after this.
Over to you, Lekha, to take the discussion forward.
Yeah. Dr. Pavna, would you like to summarize?
Yes, ma'am. First of all, thank you so much, Dr. Dhanasekhar. It was a wonderful presentation and it was an exclusive talk on IBD and nutritional therapy. It was an eye-opener for us and it was a great pleasure to hear from you, sir. And I thank Lekha ma'am for inviting me. Otherwise, I would have missed such a great opportunity to hear from you, sir. I think few of my colleagues have also joined here from Nepal, and they must have enjoyed your talk and got benefited from your experience and all the practical issues that you have dealt, starting from basic level, pathological, cellular level to practical level, what is good for the patient, how practically it can be improved. And it was surprising that you show so much comparison and RCTs where steroids and this exclusive enteral feeding, irrespective of the formula, it gets benefits to the children. And rightly you said that in Nepal, in various developing countries, the accurate formulation, hydrolyzed formulas are not available easily. In that context, your experiences sharing was truly eye-opening for us. And also you talked about the food triggers and how it is compatible, like compliance is good. If you counsel, if you start the diet therapy, the outcome obviously is good, but compliance is also good, which is very important so that the relapses does not occur, because it is not a one-time disease, one-time cure. It is a lifelong process, and it is always a challenge for a pediatrician like us that we are nowadays, it's so rising issue that once in a while we come across IBD as a general practitioner also, it's coming up. So in that case, this kind of exposure is very helpful for us, because optimizing nutrition for them is very challenging. Because along with the remission and the therapies, we also have to think about psychosocial aspect of the patient as well as the parents. And also we need to consider on the growth and development of the child at the same time, because we mostly diagnose it early. Before 20 years, it is seen that 1 in every 4 cases have been diagnosed in less than 20 years of age nowadays. This year presentation has sum up all these aspects, and I thank you, sir, for such an elaborated presentation. And as you have talked about microbiome, I also feel that westernization of food culture has also some impact in maybe rising incidence of this, because the microbiome changes does affect with the quality of the food we take and the fiber content of the food, which is, I think, is less in Western form of food. So maybe you can enhance in that the values of the food that we intake.
Sure. Thank you. Thanks very much for your comments. So basically, one of those things, it might be a completely different way of looking at this whole perspective because I don't think actually people have thought about it. So whenever you actually do a colonoscopy for a patient, right? So you talk about an IBD patient or a suspected IBD patient, the first thing you do is a bowel prep. So you purge everything, whatever's inside. So in that way, you're probably trying to get rid of a lot of all the bad stuff from the gut, and you're starting to actually do the same thing again and over. So when you actually re-establish them with the nutrition, I've always noticed that they do better. So for the patient who has been treatment naive and who has never been treated before for IBD, the ones who come to us when we do a bowel prep and start, they do actually very well. So for us, it might be that most of our patients are very naive. But saying that, westernization certainly has messed up. The reason is because I always think two ways of looking at the coin. One way is to basically see that have I have not looked at IBD in the past, or am I looking at more IBDs now? So the answer to the question is I'm starting to think about IBDs more now. The reason is on a basis or a weekly basis, I at least so close to diagnosing an IBD patient every week. So my pickup rate for IBD in pediatrics can be 1 to 2. The reason is because, very simple, we don't overdiagnose. I'll tell you why we don't overdiagnose. Because you look at a pizza, right? There are 4 pieces to a pizza. So the 4 pieces of a pizza is basically your history, your endoscopy, your imaging, and your histology. All put together gives you diagnosis of IBD. So if you think we are overdiagnosing, of course we're not, because it's 4 pieces of the puzzle we put together, and that's exactly what it is. And that's why I would say that patients from India, Nepal, Pakistan, Sri Lanka, we are seeing more and more IBDs now, because certainly we are losing a cultural value, and westernization of the diet alters the gut microbiota, which if you remember in the one slide I told you, there's one slide if I like and I want to choose, I told you about the microbial internal milieu of the intestine, which is where the whole problem starts. So the gut microbiota matters, and I personally feel that we're going to see more and more IBDs in the days to come.
Sir, Dr. Dana has checked about in the chat box about your experience with Crohn's disease affecting the second part of duodenum. So can you share some thoughts on that?
Yeah, the interesting thing is he's not quoted the child's or the person's age, because that's one thing I would like to know. Because here, if it's an adult patient or a child, if the second part of duodenum is affected, basically I can see that Dr. Putter's done a diversion procedure where he's done a gastrojejunostomy and the patient is actually done, and that is important. Now the problem is, why did the narrowing happen in the first place? Theoretically, the narrowing is called a stricture. So if you have a stricture in a patient who basically has IBD, that is not good news. That means the inflammation is circumferential, and you can see that the hole is trying to close itself together. So by putting a balloon, you're dilating. Now, if that stricture was in a place where endoscopy could not be accessed, say this was in the jejunum or in the ileum, what will your treatment be? So that was the question which I said. The only person I will not invite to my IBD party is Dr. Pata, because the first and foremost thing what he would love to do is cut, connect, plumbing, job done. But then the problem is the disease is active, the stricture is going to come again. This patient whom you're talking about is the one I mentioned in my talk, that this child is, or this person is going to get benefit from 2 things. One is exclusive enteral nutrition, and 2 will be biologicals. This person would be an ideal candidate for biologicals, whether you talk about infliximab, you talk about adalimumab, you talk about vedolizumab, or you talk about rituximab. Any biological in this patient would possibly make a difference. And I think that's what you need to really consider before the patient develops another stricture in the due course of time. And also, by doing a diversion procedure, what we've done is we have changed the gut microbiota. So the patient is probably going to be more dysbiotic now. And in this patient, your exclusion diet will certainly make a big difference. I hope I've answered your question. I know it's a very long answer, but it's very important that we look at this very, very comprehensively, because if we don't look at it comprehensively, this patient is going to come again.
Sir, we have another question from Rachna. I believe she's from Nepal.
Yeah.
About some lights on microbial treatment on IBD. She would like to know about that.
Right. Okay. So interesting question. Now, any guidelines that you actually use for microbial treatment is only from a particular body called WGO. If you're not familiar, this is called as the World Gastroenterology Organization, and they have some fantastic guidelines on using probiotics in IBD. The only probiotic that can be used in IBD is basically called as VSL3. It is basically a collection of 6 probiotics that are being used together to actually help in a condition called pouchitis in ulcerative colitis, and that's the only drug that is approved as an usage for antimicrobial treatment. Now, are you talking about fecal microbiota transplant? No, we used to use fecal microbiota transplant in patients with the resistive Crohn's disease who will not respond to any other treatment. But what has happened now is that has not been licensed as an indication in the management of IBD. So fecal microbiota transplant is no. So the answer to the question is probiotics in IBD is in only one indication, and there is no role for fecal microbiota transplant.
Thank you, sir. Sir, it would be great if you could set some experience on preemie babies about having neck and even on STROMI neonatal course. How do they develop IBD?
Well, unfortunately, we have not seen that many cases, to be honest, because the reason is very simple. We have not seen that many, what you call neonates who graduated out of NICU having IBD. Because I think that will be a really, really bad thing to happen. Because if you've had NIC and if you actually come out without any problem, then you're fine. But imagine if you had an end-to-end resection, or if you have an end-to-end resection anastomosis, or if you've had colostomy, they actually will be very bad candidates to treat if they have IBD. But thankfully, for some reason, there is no direct correlation between NEC and IBD because I have not seen a direct correlation in this category, and that's basically for now a very good thing. But things might change in the future, and I don't think NEC has got any direct correlation with IBD as of now.
So just to share some experience of mine, like when we are having this babies, to manage the child is much more easier. I feel like the initial period, we tell the parents they have a difficulty to adjust to that. But I always feel that the kids, they're more easy to understand, and once they start on the feed, they are so comfortable with going with EN.
Yeah.
So it's like, it's only the start what they need to do. But parents are the one, who have the main constraint how to keep on like without the feed. So that's what I would like as a dietitian preceptive would like to say that, once started, then it's good.
Yes.
Good to go.
Very true. Very true. I completely agree with that. Yeah.
And nowadays we are getting various flavors are available than what we started initially
Oh,
10
yeah.
years back.
Far
So
too
those
many. Yeah.
flavors of adding on the strawberry flavor or chocolate flavor, those polymeric formulas or even the hydrolyzed formulas are coming up with flavors. So I
Correct.
feel nowadays to manage EN is become more easier than what we faced some years back.
Absolutely. I completely agree with you. Yeah.
If anyone else has any questions or comments, please feel free to type them in the chat box or to
They can even
turn on your camera. We'll be happy to have you, happy to listen to you.
So,
I can see another.
Yeah, ma'am.
So as we come across other questions, may I also, like I have also a query I would like to ask to you, sir. So, may I, sir?
Yeah.
So, as we have talked about the different forms of foods, triggers and all, so is there a rule like the texture of the food, the same food but the different texture? Does that make difference for the child with IBD?
No, it doesn't actually at all. The reason is because the texture really doesn't matter because food allergen sensitization, irrespective to whatever texture you give, is going to happen. So that really doesn't matter. So the answer to the question is no.
Okay, thank you. So there is another question. I think I'll pick up that as Can probiotics be used on regular basis as a supplement to prevent IBD? So that
There
is
is no probiotic which is basically going to prevent you from getting IBD, unfortunately. The reason is because there is no direct correlation. And I don't think probiotics is the elixir for all the problems, because none of these probiotics is going to prevent you from getting a disease. It is going to support wellness. It can prevent some illness, in inverted commas. It is not going to prevent IBD. In fact, the problem is, if you look at the data, I will tell you one interesting, it's not an anecdote, actually, there's a very, very important fact. If you relocate from India and go to the United States, or you go to the United Kingdom of any part of the Europe, as a child, your risk of getting a non-communicable disease is extremely high under the age of 15 or 16. So you're likely to become obese. Do we all agree it's a non-communicable disease? You're all likely to get fatty liver, which is going to be a non-communicable disease. Your risk of getting IBS, of living in a place which is completely alien to, is very high. And your risk of getting IBD is very, very, very high. So basically what we have started doing is, there is an IBD basic study that is going on, where we collect samples, which is a collaborative effort between me and the University of Munich, where we take samples and send them and try to identify what genes are basically going to cause you IBD. And when you look at the Indian gene sequence, of all the 24 patients I've sent, we have not found any genomic sequencing anomalies in our Indian patients who have lived abroad. But if you are thinking about going to live abroad with a child who's under the age of 15, your risk of getting a non-communicable disease such as IBD is very, very high. That can be attributed to external factors and even altered to your gut microbiota, and that's what has been hypothesized. So me and Lekha have dealt probably in the last 1 year at least 10 to 15 patients who come from Poland, who come from Turkey, who come from Germany, who come from America, who have come to for a second opinion, third opinion in Apollo, and we find that Indians who are living abroad are very likely to get IBD. So there's no chance. If it is going to come and get you, it's a real demon, it will get you. It doesn't matter where you are. If you're lucky, you will escape. So that's basically the law of probability as of now.
Lekha, if you have anything more to add, and
yes, sir. Sir, how about kids who are into sports and then they are with EN? Some idea about that?
Yeah. So basically, as I said before, the most important thing here is the calorie requirement that you need to meet. If you're talking about EN, you talk about PN and exclusion diet, or just isolated EN. The most important thing is that these children, during that point of time, we need to ensure that we give them adequate protein to maintain the muscle mass. So if we don't give them adequate protein and you put them exhausted, the calorie requirement that you're going to give them, that 120%, is actually going to be helping them in their healing process, will not be helping them in achieving and maintaining the basic metabolic rate. So that is a thing that I would be really reliant on you, that you need to take protein. Because when I talk to a general physician, the first thing they tell me, for anybody who's well, the first concern they say, are you above 40? Yes. Your risk of sarcopenia is very high. You need to take 1 gram protein every day per kilogram for the rest of your life. And you think, what? You're 90 kilos and you're going to take 90 grams of protein every day? No ways, because that's impossible. Because we all know in India, according to the ICMR guidelines, we're very poor protein intake takers, number one. And you know what will happen if you take a lot of protein? You're going to be farting all day. And that's not going to be very convenient for a clinician to do that. So these are the two practical problems. So we have to understand everything has to be customized for your patient. And that's where the nutritionist really comes in. Without them, it's very difficult to work. We cannot draw a plan, because if not, the patient will be just taking some protein supplements which have got banned substance like steroids and anabolic stuff, and they're going to come back with kidney failure or liver damage. So that's where you need a professional help.
So maximum up to around 2.5 to 3 grams per kg should be fine.
Yeah. You know what? Actually, that's perfectly fine. But just imagine, can you really manage that much protein?
But I feel like with the EN, we are able to get, sir, right, with the formulas. I'm talking about especially if they are into sports or something. So during that time, probably, we can just mix and match with the products what are available and go at during that
Yeah,
time,
of course.
probably.
I mean, I know it's very challenging. I just
Very
wonder
challenging.
how sometimes you guys do this job because sitting
It's
down and
really tough. This
yeah,
adjustment job is something which is really a tough thing.
you need to know what the family likes, what they eat,
Exactly.
what they will compromise is basically very, very difficult.
Th- there's one more question comes from Dr. Nala saying about biological treatment is a pharma. They may make the money, not all can afford. So when Crohn's reaches a critical stage, once again, Dr. Pata and surgeons can let the patients carry on.
Well, that's. I think you have to look at everyone's perspective because what we say is there's nobody who's working for free, are we? The pharma is a bureaucracy, nutrition is a bureaucracy, surgeon is a bureaucracy, doctors are. You can just label it whatever you want, but we need to see what's best for the patient's clinical outcome. And unfortunately, one of those things that people very find it very easily. I want to use this as a particular quotation because I remember when I left medical school, my professor told me two things. One, are you sympathetic? Are you empathetic? So the answer to the question is, if you have the disease, how would you feel? Put yourself in the patient's shoes. It's very, very difficult to actually manage a chronic, lifelong condition that has got a very high risk of becoming a malignancy later on and can affect your children as well. I think that is basically where it is. So being the patient yourself is empathetic, being kind to the patient is sympathetic. We can do million things and easy things. And poor man, I think Dr. Pata has been bombed here because everyone's just dragging him now. But as I said, I want the knife of my patient for only butter. I don't want the knife to make him better.
So, Radhakrishna, would you like to come in now?
No, he's
back.
he's quit. Roger that.
Sans knife, Radhakrishna sans knife.
Much water has flown under the bridge, I'll tell you, and I've been dragged in a number of times. To start with, as expected, is a wonderful lecture by Dhanasekhar. The only sad thing is that he kept on pulling me. But then I'll tell you my experience with Crohn's disease. See, during my undergraduation, I haven't heard of it actually. In All India's Medical Sciences, we used to operate at least 5 cases per week of ulcerative colitis. I don't know, it was so common then. Crohn's wasn't common. Now, in the last 10 years, I've been working with Dr. B.S. Ramakrishna, who's known for Crohn's disease. I've seen enough number of patients. I assure you, in the first place, I never operated on any patient where there's no indication, but I'll come to it later. The interesting part is where I always understood that Crohn's disease is a rich man's disease, or otherwise happens in countries with very good hygiene. I'm surprised why it's happening so much these days and so common. What made that? There's a question for you to answer. I have a couple more questions, and you can come into it. And when you were talking about, changing gut microbiota, a number of patients I've seen and well-to-do engineering graduates, but they're not overeating or they're not abnormal in the eating habit, but they still get it. Two, now these patients lose weight tremendously. And I don't know how will it be in children. I mean, they must also be very sick. Now, I'll tell you the first case I operated in Sims Vadapurni when I just joined Dr. B.S. Ramakrishna is a 35-year-old professor, lady IIT, who came to being treated for Crohn's for a long time, had perforated small bowel. I mean, she succumbed anyway because we took it and we resected that segment is got adenoCA. Now, why I am coming to this is we had seen so many patients who are on, liquid diet and medication and lost 25 kilograms of weight. And when their skin and bones only, we had operated on them. I think the treatment has been prolonged and extended, trying to avoid a surgeon. See, I mean, surgeons are reasonable. I don't say that they're just simply either knife happy to cut and see. That doesn't happen. And, we shouldn't, I very strongly feel at some point of time, the surgeon and the physician, the radiologist, and the surgeon should sort of make combined decision and see how the patient is evolving. We've seen a lot of adult patients with a lot of complications, especially internal fistulae and cutaneous fistulae, bladder fistulae, all sorts of things we've seen and we had operated. So surgeon should come in as a last resort. He should be taken in at some point of time. It's very interesting that more and more children are getting. I don't know why it's happening now. The another important point which even Dr. Bhavna is mentioning, that this is a continuous disease, is incurable. We had operated a number of patients. We have a series actually, but I haven't seen anybody coming with a recurrent disease requiring intervention. I think whether that is a truth or myth, I do not know. That we take off one segment off, and after some time we had to go in for another segment. I don't know whether you had seen. You might be seeing patients who had surgery earlier and come back with recurrent cross. There are too many questions. Dhanasekhar, please come in.
Very much here, sir. Sir, love to hear you. I'll tell you why I said that, because the reason why we don't want the surgeon to come along the party is because the most important thing is we actually have an expanded arm of treatment nowadays that is available, because I think nutrition has got a very key role to play. Nevertheless, do not forget that we are not only talking about oral nutrition here. I've seen perianal fistulas healing very beautifully with IV or parental nutrition. That's one of those key factors. And the second factor is biologicals, because I know we have different thoughts about biologicals, but I think one of those things we need to understand is when you start using it, you start appreciating it, and you actually know that it actually works. But long-term side effects, of course, people start questioning. There is no medicine that, as I said, one of the things I was taught in college is there are no medicines without side effects, but we don't see it in all of them. So the last time I operated a patient with IBD, or I called upon a surgeon with IBD, I could not remember. It was probably years ago. And the reason is because I think most of the things, not that we are learning to manage it effectively and better. And surgeons were never the forte or the first line of treatment in IBD to start with. But when things go out of control, when they're sick, when they have a toxic megacolon, or when the child really needs some surgical help, of course, yes, it actually is one of the things I would want my comrades to come in and to sort it out. So I think, of course, one of those things in pediatrics, we want to preserve the gut, and we want to preserve it as long as possible. We don't want to cut it. We don't want to resect it. We don't want a 15-year-old child to walk around with a colostomy bag when things can be managed with drugs. And that's basically what they prefer to. So that is one of the psychosocial aspects of management of IBD in children, because cosmetically, any treatment that you do should not disfigure them. And they're very particular about it, especially when they're teenagers. They want to look good.
Another point, Dhanasekhar, I want to mention here. Vidya, please get Dr. Piyush in, because Piyush is an expert in inflammatory bowel disease after I finish. See, we see a lot of patients where no proper diagnosis is available. In spite of whatever you do, you have a biopsy report saying non-specific inflammation, and and still the patient, I don't know how you get a thing like that. You have diagnostic difficulty in your pediatric age group, because in adults, a lot of patients have no definitive radiological or histopathological diagnosis, and some of them get treated as Crohn's.
Right. So the thing is, one of those interesting things what we see in children is there are three categories of diseases. One is Crohn's disease, ulcerative colitis, and third category is called as indeterminate colitis. And we see a few of them evolving into a proper IBD when they get to adulthood. So the important thing here is when we actually send the patient to you or to any gastroenterologist, we have done our part in making sure the child has grown well, has developed well, has got decent muscle mass, and then the disease evolves as it goes. Because the nature of the beast in IBD is very, very difficult, because now the best part is we are starting to think about it. So now we have another category of IBD, which you might actually find. There are two more new names. One is called as VEO IBD, which is called as very early onset inflammatory bowel disease, right? That's number one. Number two, we also have another category, basically where you will see it is called as monogenic IBD. Now, monogenic IBD is even more difficult because These children get better only with a bone marrow transplant because we know they have a genetic defect. Then we have the colitis where it becomes non-specific colitis, post-infectious colitis. Sometimes when you actually have IBD-like picture, the important thing that we have to look or not overlook is to consider tuberculosis as a diagnosis. Because India, Nepal, Sri Lanka, Pakistan, all these countries once upon a time were treating or probably treating all the Crohn's disease as TB and TB as Crohn's disease, which we don't know now. We have better diagnostic ideologies now. We know exactly where we're going. We have better ways of looking at Crohn's, so we can even do a small bowel enterography using an MRI. We can use basically a pill cam, or we can use even a double balloon endoscopy to actually look at the disease segment specifically to give us an idea as to what we're dealing. So I think the most important thing we need to try and understand is to get the diagnosis right and get it right the first time.
Yeah, one last thing with your permission. We had a couple of children between DSR and me that, that suddenly grew after that, the whatever disease segment is resected. In Dr. Ramkrishna himself was surprised at how these chaps, they become unrecognizable. There must be some set of children who definitely have that growth. If somebody is not growing normally, you should also think of a surgery.
Yeah, so of course, the thing is the disease segment once are dissected. But then I'll tell you what, you should be really lucky because Crohn's, what I tell Lekha, and I always told the first, is basically a very, very nasty disease that does not localize to one particular segment. So 1 month or 6 months it can be in the bum, next few months it can be in the mouth, then few months it can be the small bowel. We have seen a Crohn's affecting the esophagus, and that can be a very, very difficult disease to treat. So if you have disease in one segment and I have a lovely surgeon like you who can do the plumbing, disconnect and connect again, then my life is I'm very happy. But the disease is spreading and is not in one place, then it's going to be very difficult. And that's exactly why I think you need to pray to Lord to give you a small bowel Crohn's affecting only the jejunum, about 2 feet, and have Patasar as a backup, and then I'll be hunky dory, well and good, and I'll be fine. But that is in a dreamland, that's never going to happen.
Dr. Piyush, we'd like to hear from you.
Thank you, Vidya. Thank you, Radha. The only thing I wanted to add was that I think what the point made was that you can't ignore the surgeon. There are situations where you will need the surgeon. If you have a perforation, you can't sit over it. So I think it's very important, and what we've learned over the past decade or so before I retired, we started. This was in fact from our physician colleagues. That you start doing multidisciplinary discussions on particular patients, and we'd get the pathologist, the radiologist, the surgeon, the physician, the nutritionist, everybody on board, sit down together and discuss the patient. I think the days have gone where one can be dogmatic about, one way or the other. These diseases are evolving. We're seeing much more Crohn's than we used to see. We're still seeing a lot of ulcerative colitis. We're seeing it in young people as well. And though I deal or used to deal with largely adult patients, we did occasionally have a referral from the pediatrician because the pediatric surgeon wasn't comfortable dealing with the disease because they'd never seen the disease. So I think what is important is to not be very dogmatic. Yes, the biologicals have made a huge difference. I think it's also important that in children you don't give them stomas, and no surgeon is keen to give stomas to anybody, children or adults. But nonetheless, there are situations where you will need to do it as a life-saving procedure. And to banish the surgeon unless the patient has skin and bones is not a great idea either. So that's all that I wanted to say. Thank you.
So Dr. Bagdi, a pediatric surgeon, has a question. You clinically diagnose appendicitis and put in your laparoscope and findings are suggestive of Crohn's disease. What do you do? I don't know, Dr. Dhanasekhar, would you like to take that question?
You're muted, Dhanasekhar.
Yeah, I know our good old Dr. Bagdi, who's our senior pediatric surgeon, would love to ask a question that complicated as it is with the amount of experience that he has, and I'm sure he's done this several times. Anyway, thanks, Dr. Bagdi, and we still love you for all the classes that you've done for us. Yes. Now, when you've gone in and you find that there is appendix basically that's inflamed, the first and foremost thing is that if the appendix is inflamed, you can of course remove it. But the most important thing is please do send the appendix sample for biopsy because the appendix can give you the diagnosis of Crohn's disease. It might even save the life of the child from going back in and doing a complete endoscopy and colonoscopy because our CT angiography is now so improved that it can save that. And one of the commonest things that can get missed out is when children have an appendicectomy done, the appendix is not sent for a histology, and that is what Dr. Bagdi is also trying to tell you here as is one of his hidden secret messages, that if you ever do an appendicectomy, do send the appendix sample to the lab and get the pathologist to clear it's only an appendix and nothing else. So yes, that's my answer to your question, sir. And thanks very much for asking. We love you as you were before. Thank you.
This is an exam question, Vidya, of when you suspect Crohn's disease, when you do an appendectomy. Unfortunately, we cannot suspect Crohn's disease. Put a laparoscope, the appendix is inflamed. We don't know whether inflammation is due to fecal or due to Crohn's disease. It's ideal that we shouldn't do an appendectomy when it's Crohn's disease. But I think this will give us a thing that whenever you're diagnosing appendicitis in a child, and you should have a definitive CT scan, and the CT scan, there is some suggestion of Crohn's disease. Please look for Crohn's disease, signs of Crohn's disease, in every case appendicitis. And if you find some, you be careful and maybe we should manage conservatively. I mean, that's pretty message, because once you resect and it will fistulize and then it becomes a huge issue. And it becomes some medico-surgical thing, difficult to treat. Imagine a post-appendectomy fistula, non-healing, and some feces coming out. We've seen that happen. So you keep appendicitis, whenever you see an appendicitis, you have a proper image and keep in mind that inflammatory, we look for any signs of inflammatory bowel disease. Yeah, good. Yeah.
So we don't seem to have any particular question. No, there was one question from Dr. Venkatesh.
What about some popular diets about Atkins, keto, low carb diet, sir? Your thought on high fat, very low carb diet, all that.
There is
most popular diets.
I know, but the thing is, one of the most commonest discussed, trolled, watched, and spoken about topic in all social media is diets. And we know that everyone has got a secret recipe in their bag. I think everyone's got something that they are releasing it every week. We know that there are a lot of diets that have been time tested, and we have shown that it's not really worked. Atkins diet for IBD, definitely no. And basically any other diet that I've not spoken about this evening, I'm just going to put my thumbs down and say definitely no to it. Especially when you are going to ask this question about IBD, because IBD is basically a very, very sensitive thing. It has to be dealt carefully. It can get completely messed up. And I will tell you why, because there are people in India who actually go, the moment you tell them it's a lifelong disease, it's a chronic disease, and that needs treatment, you know where they will go? They will go to Ayurveda, homeopathy, and basically Siddha, because I think that is the most important and dangerous thing than compared to basically your Atkins diet and non-Atkins diet. That child, when it comes to you, is basically one that is completely messed up. I've got a patient from Singapore who actually has been on multiple different Siddha treatment, and the disease has only got worse. And we have to literally set his clock back and do everything. So that is the unfortunate thing about children, because they cannot make their own decisions. And their life can be getting completely messed up by parents who are, they're ignorant, they're naive, they don't understand, and they go and fall trap to all these things and make a mess of their life. So I would say no to any other diet which I've not discussed this evening, because all that effort I've put in to make the presentation will be a complete no-brainer if I say yes to any other diet.
Dr. Dhanasekhar, I think the point he was trying to make is also in general, not obviously not as treatment for IBD.
I know, ma'am. That's exactly why I said pertain and restricted my answer to only IBD, because I don't want the audience to take a mixed message this evening, because all the other diets are basically I've got good and bad things. That's going to be an extensive topic in itself altogether. Ketogenic, non-ketogenic, Atkins. So with pertaining to IBD, the answer to your question is no. We stick to what we spoke.
So, Lekha, like I messaged you, we're not trying to promote any brand or anything, but just for somebody to have a easy, sort of a ready reckoner, if you could just name some of
I
the.
have just listed down few of the. I have done that reply.
Okay, right.
I've given some few ideas about what is available. Any of the polymeric formulas which are available can be used. When they're not tolerating, probably a hydrolyzed formula, whichever are there in the market right now. Only thing the dietitian needs to make a little bit tailor-made to understand what is the requirement and adjust the formula accordingly. So that has to be like, it cannot be like a standard formula for all. Probably sometimes we need to do some alteration changes.
If you could just, give a typical, what would be a diet for let's say a particular age, particular weight, what you would do just for
How we
completing.
do means like, say, for example, it's a 2-year-old child who comes with Crohn's and we need to start with EN. First thing will be, we'll have to look into the diet recall to understand how much the calorie the child is start taking that. Because as we said, our goal is to meet 120% of the requirement. So instead of the requirement is around 1200 and the child's intake is around 600 to 700, we start with that of that 600 and 700 calories only at the initial 1 to 3 days. So the formula, what we are going to use, the regular polymeric formula, you give the calories around that 600, 700, then slowly look into how the tolerance is and gradually increase. So in a day of 2 days or 3 days, we can slowly go up and then try to meet that 120% of the requirement. So that's how the EN is being formulated. Not like, we make it at a fixed, this is the dilution. So based on, like, again, if they are not able to tolerate that normal polymeric formula, you think about going for the semi-elemental formula, we can make the alteration in the dilution. So instead of going with the 1:1 dilution, we can make it as 1:1.5. So probably I feel like, all the consultants should have one of the dietitian along with you. We are there to help you out in that. You can take care of the medical part and we are there to help you with the dilution. We can adjust that. So each day, talking with them, understanding the recall actually helps us to formulate that. So that is how it has been done, Dr. Vidya.
Thank you for that detailed note, and we'd like to hear your closing comments, Pavana.
Yes, ma'am. Well, it was a really fruitful discussion, inclusive from pediatric surgeons, dietitians, gastroenterologists. So it was a total, in one go, we have discussed so many complications and how to deal with it. So it was very fruitful for a general pediatrician to know so much of knowledge I could gain from here. And I would like to thank each one of the participants who have attended here, which has made this session a successful one. And thank you once again to the Dhanasekhar sir for his exclusive presentation. And it was a great learning session for me and my colleagues.
Right. Lekha, your closing
We
comments,
have
please.
Dr. Nalashivam who wanted to share some of his experience. Sir, over to you before we wind up, sir.
I thought
Okay.
Nala deals with obesity and bariatric surgery. Where does Crohn's disease figure in Nala?
Well, my experience in Crohn's disease started.
Just a small interruption. This one, Nalla. Pavana,
Sorry.
Nalla Shivam is an anesthetist. You
Yeah.
named a lot of specialties. So I'm an anesthetist. He is one. We had a nephrologist, and
I didn't know that.
we even have ophthalmologists and microbiologists, and name it. We have all kinds of specialists who have logged in. So
Okay, so
that's
it's
why I was
But
very keen to have it more general, and some things you people will take for granted when you say EN polypop. This thing, you know what you're talking about. Rest of us don't. So that's why I asked for the extra details. Over to you, Nalla.
thank you, Vidya. Now, I just wanted to share because my experience with Crohn's was with my chairman, who is the owner of the whole medical industry in DM Healthcare and the Medcare Hospital. Now, my point was, I'm not. I know the topic was with pediatric. Now, definitely, Crohn's go is a it's a chronic disease that goes on for life. So once you cross the pediatric type and then you get into adult life, I was more focused on to Crohn's involving the CBD system, the second part of duodenum, not the ileocecal area, the ileum. So my chairman had all that, and then we were going through a lot of trouble. One of the main things that what he said is Crohn's is always triggered only with the food. Yeah, the diet is what that goes in and triggers the Crohn. My chairman was on all biologicals and he could afford everything. End of the day, every year he used to get an attack of pancreatitis, and then he used to be on the bed and we had to treat him. So we all sat together and we said, yeah, let's go ahead with the diversion procedure. That's why I was naming Patta. Surgeons are definitely to be involved, not only when there is perforation or something, even prophylactically. If you do just a gastrojejunostomy and prevent the CBD system getting alerted by the diet, it just makes a lot of difference. And we found that. And that made me so happy. And my chairman is still going fine at 75 now. So this is what I want to share, that surgeons cannot be kept away, not only when the acute phase, but even prophylactically you can come in, because Crohn's biologicals is like a pharma industry. You're talking now today because Rashika is talking now because the biological industry has come a big way now. 20 years back there was nothing. It was only prednisolone and the same same dexamethasone and prednisolone. That's all tablets. So now you have biologicals, but then diversion pathway did treat a lot on the second part, the upper part of GA, which is being affected by Crohn's. I just wanted to share that. That's what was my view. And I don't know whether he'll accept it or not, but it has made a huge difference. And my chairman is very happy for what I did. And then it's been going on for a long time now. And I've been propagating it to everybody, every surgeon I see. And Pata, I put the name Pata because he said surgeon. I said Pata. Pata is not my surgeon. I've never. Anyhow, that's just off the light. I just wanted Rajshekar to say what does he feel about a diversion pathway, which will take the diet, the food that is the one that's going to aggravate the Crohn's, exacerbate, prevent, give a acute condition apart from the biologicals. That's it. Thanks, Vidya. Thanks, Pata. Sorry, Pata.
Do you want me to comment on that, sir, or do you want to close it, ma'am?
Sure, please. We'd like to hear your response because
Please.
See, I think one of the things where not to the pharma industry, nutrition has come a long way, and we are trying to understand that what we eat actually triggers or reduces the impact of the disease what we have in our body. We talk about diabetes to obesity to challenging diseases like fatty liver and basically things like IBD as well. So to just to draw things to a close, I think as I said before, you have to customize what suits you and you have to see what doesn't suit you. And by the time you explore and find it out, I think we are all too late into our life already. So we have actually got the problem and then we start exploring what doesn't suit us. So it's one of those things I think we need to keep our eyes and ears open and all together working as a team makes a real deal of difference to our own livelihoods. And that is something what I want to leave everyone with a take home message that nutrition is the key point in our well being and can be the preventive treatment for a lot of diseases as well. And in the long run, that what plays a really, really important and key part. Thank you very much and good night all.
Dhanashekhar, the point which Nalla was mentioning is there's a disease segment. If you divert the food from the disease segment, will that help? Because in Crohn's, I don't think that will help. It helps in ulcerative colitis, especially in acute exacerbation, sometimes you do an ileostomy temporary because that will bypass the colon and patient can sort of come out of it. I mean, that concept, I think in Nala's chairman's issue, maybe it hasn't caused or aggravated pancreatitis, but, I mean, there may be some funda behind it that he made
So
some diversion.
we would do that on a very, very, very handful or cherry pick patients, sir. That does not apply to all. And especially in a child, especially because me being a pediatric gastro, that is not the first thing that would come to your mind. So let me put it that way. So diversion procedures can be considered, but very rarely done, sir.
More like an anecdotal thing. Today
That's
we
right.
are focusing on the majority.
But there's some funda in what Dr. Nala says is that, like, for example, when the patients see many a times these patients are put on liquid diet. They can't take anything more because the lumen is there. The thing is that lumen will open up with medication. So during that process, if you keep the nutrition on by, bypass, whatever, I mean, that's just a hypothesis. I'm just wondering. But at some point of time, the disease segment will open up after inflammation subsides. I mean, it thought that possibly that causes nervousness.
So thank you everybody for, I mean, though it seemed like a very niche topic, but despite that, we've had a good number of people from different specialties, not just pediatric gastroenterologists or dietitians who have joined in, and that's what I had requested Professor Dhanasekhar to pitch it to lay person like us, who are not into the treatment. Because as an anesthetist, the only time I come across these patients are when they come up for endoscopy and anesthesia, and definitely we are seeing it more. That much I could also figure out, that we are seeing more and more patients with inflammatory bowel disease, especially children. And they do look malnourished, and they're not doing well in school, and this parents relationship between parents seem fraught. And so now that I have a better understanding of what's actually going on in their lives. So thank you very much for a very informative and interactive session. We kind of allow some free for all towards the end, so I hope you do not mind that. So we'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.